Welcome back to Mysteries of Health Under a Lens. If you are new here, I am a doctor currently completing my residency in pathology, and my goal is to help you understand what's happening at the microscopic level. Just a quick disclaimer before we begin. This video is a professional medical review intended strictly for residency preparation, lab analysis, and objective diagnostic education. I will be focusing purely on the high yield biopsy findings and underlying disease mechanisms rather than clinical management or treatment protocols. Please do not use this information as a replacement for medical advice. Today, we are going to break down a new topic, that is plasma cell neoplasm, a case based approach. Alright, then let's get started.
To discuss a case along with starting from the clinical presentation, laboratory findings, and then coming to the diagnosis. And then at the end of each case, we will discuss some facts or some facts about the disease. Occasional, you will also find occasional historical fact related to the disease, because plasma cell neoplasm has a strong history, and there are interesting historical facts. So we'll start, and I have Dr. Neeraj Arora with me. This session is going to be combined session, so I'll take first case, the second case will be taken by Dr. Neeraj, again third case I will take, fourth case will be taken by Dr. Neeraj. So we'll take alternate cases, and and I'll be happy. We will be happy to have to answer you if you have any question in between. Feel free to ask any question in the middle of the talk. This is more like a discussion than a presentation. Okay, so let's start. Now let's go through some understanding what are the plasma cells. So plasma cells are basically the terminal stage of B cell. Okay, it's a B cell stage, a B cell which is differentiated, and the last stage of B cell differentiation is plasma cell. So if you look at this figure, this cartoon figure, you can see the B cells develop from the hematopoietic stem cell in the bone marrow, and they undergo development. We all are aware of the term hematogones. So we know that in bone marrow we have hematogones which go through multiple stages. And when these hematogones mature, they become mature B cell, naive B cells, and a majority of these B cells enter into the lymphoid tissue. There they interact with the T cell, exchange the information through the antigen presentation, undergo class switching, and then proliferation. So the B cell in the lymphoid follicle, and then some part of the cells, become short-lived plasma cells, and some part of will become long memory B cells, and this memory B cell further differentiate into the plasma cells. And these plasma cells, so basically B cell proliferation happens through the interleukin 4, which is secreted by T cells, and this interleukin 4 causes B cell proliferation and differentiation to the different B cells and the specific plasma cells. And these plasma cells, then some of these plasma cells re-enter the bone marrow, and the bone marrow gives them the niche to survive and function, process their secretory function. So this is a complete homecoming of B cell. You can see the B cell precursors start from the bone marrow. They move to the circulation, from circulation to the lymphoid tissue, and from lymphoid tissue again becoming memory B cells and plasma cells, and these plasma cells ultimately return and home to the bone marrow and other lymphoid tissue. So this is the development and maturation cycle of plasma cell. Now this is the last WHO you can see there, and which shows the different classification of plasma cell neoplasm. There are many entities. Today we will focus more in the plasma cell entities, plasma cell neoplasm, and what we include is monoclonal gammopathy part will be. Okay, we'll not cover all this because this is not possible to cover all diseases, so we'll focus on the plasma cell neoplasm in this. So let's start with the case one. Do anybody have any question till now? Then the differentiation of plasma cell. Okay, let's start with the case one. Now, this we had a 48-year male patient who presented with a backache for last 6 months. Also had a weakness, but there was no history of trauma or fracture. And on examination, the physician found that there is a pallor, but no pedal edema. The chest was normal for abdominal examination. There is no hepatosplenomegaly. And the cell counter CBC was done, and then CBC you see the hemoglobin was 6.8. So there was severe anemia. And this is complete CBC CBC in our hospital. You can see the hemoglobin was 7, which indicates marked anemia, and then in the RBC count is relatively low. MCV is slightly on higher side, but still in the normal range. RDW you can see this higher, and platelet count is also low. So platelet count 1,09,000. WBC counts on higher side, that is approximately 14,000. So this was CBC finding. This is a peripheral smear on low power. What anybody of the student can tell what is the striking finding in this peripheral smear?
Role formation, sir.
Sorry, what?
Rule formation.
Yeah, you are absolutely right. So you can see the rule of formation, the stacking of RBCs like coin stack. You can see the rule of formation is there. So it is very striking finding. Now, and this is a closer view. You can see the closer view. There is a nice rule of formation, rule of formation, rule of formation. And we have normal count. The count is slightly high. You can see there was 13,000, so that some neutrophil counts 70 to 80%. And so the patient, this because there was rule of formation, the physician has ordered for the investigation, biochemical investigation, and you can see the serum protein was high. The albumin levels were low, globulin levels were high. LDH looks normal, calcium is also low, and the other levels like urea and creatine levels. So the urea was slightly more marginal, but the creatine level you can see was significantly high as compared to the normal rate. So clearly there is the abnormal findings were there on the biochemistry. So because their globulins were high, creatine levels were also increased, and there was rule of formation. So definitely the physician and the backache suspected plasma cell neoplasm, and the tumor markers for their ordered. And since there was anemia, the other vitamin B12 and folate was also evaluated. So you can see that the folic acid looks normal. Vitamin B12 is increased actually. Vitamin B12 looks normal. Vitamin beta to microglobulin level is also high, and serum ferritin level is also high. So these were the findings. So tumor marker, the further serum electrophoresis was the protein electrophoresis was done, and in this protein electrophoresis you can see the sharp peak in the gamma region. Okay. Normally you see a very small peak, but here you can see the strong sharp peak in the gamma region, and and you can see there was a concentration of M band. So M band was detected in the gamma region. This small peak, this sharp peak is from the monoclonal band of M, and the concentration of M protein was 4.2 gram per deciliter. Then the nephelometric quantification was done for the heavy chains and light chains, and you can see the IgG levels were strikingly high, significantly high. You can see it was 5,000, more than 5,000. And with kappa and lambda, you can see the kappa was light chain were high. So it was looks like the IgG kappa was significantly increased. Okay. And this is serum immunofixation. You can see the on immunofixation also. The band was noted in G, which will represent IgG protein, and in kappa region, which represent the kappa free light. So this confirmed that, and even the free light chain ratio was strongly means it was deviated. You can see if you calculate the free light chain ratio, it looks like more than 20 times free light chain ratio. And so the urine evaluation was also done for the Benjo's protein, and it also detected kappa light chain in urine 12.2 grams. Okay, so this was the finding. You can see, so on this finding, we can see that that patient had backache. The globulin levels were definitely raised. Then the anemia was there, and creatine levels were high. Anemia, creatine level, globulin levels were high, and on biochemistry, you can see that M protein was detected, which was significantly at 4 grams per deciliter. Then the IgG kappa kind of free light chain was, and the immunofixation is also confirmed, right? So which indicates that on at least on biochemical findings and nephrometry, there happens to be plasma cell neoplasm. But can we confirm the diagnosis of which type of plasma cell neoplasm? Can we confirm any type of plasma cell neoplasm at this stage? Any Guneet, Aishwarya, do you know anything about it? Do you think this is a plasma cell neoplasm? Do we have any
Yes,
differential diagnosis?
yes, sir. So multiple myeloma.
Right. So yeah, you are right. So plasma cell neoplasm. But can we subtype the plasma cell neoplasm? What type of plasma cell? Is it a plasma multiple myeloma? Is it MGUS? Is it a smoldering myeloma? Is it Waldenstrom microglobulinemia? Any clue?
We will need flow for that.
Well, flow we don't need, but on this let's say if you consider it's a plasma cell neoplasm, and if you want to identify plasma cell multiple myeloma, do you know what are the criteria for multiple myeloma?
So slim crab.
Anybody? Yes, crab, slim crab. That is right. So if you look at the crab criteria, so we'll discuss the crab criteria. So definitely two features are there out of them. One is the creatine levels are high, right? Which indicates impaired renal function, which in the truth from the crab R represent renal function, and anemia is there, right? Right. So anemia is there. So anemia is another. So out of CRA, A is the anemia. So the renal function and anemia is there. So the two features are there, which indicate that possibly we are dealing with multiple myeloma. Now, a historical fact for the Benjo's protein. So many people, I don't know this. If you attend HematCon meeting, which is going to be in Gujarat this year, or any myeloma meeting, they have a quiz, and this is one of the common question about the Benjo's protein. Whether the Benjo's protein come from the one scientist or two scientists. So it is one scientist. The name of scientist Henry Ben Jones. No, which has labeled this protein as it. And there is a interesting historical fact. Basically, this protein was first identified by Thomas Watson from the London, from the that time British, UK. So he looked at some proteins urine and wrote to the Dr. Jones regarding this. This is a letter from him from the 1845. He mentioned that the tube contains urine with a very high specific gravity, which describes the Benjo's protein. Now listen to that. It contains urine with very high specific gravity. When you boil it, when boiled, it becomes slightly open. And on addition of nitric acid, it differences and assumes the tissue and becomes quite clear. But as it cools, assume the consistency and appearance which use. So heat re-liquefies it. So what is it? So from the Thomas Watson wrote to the Ben Jones, and then ultimately the Dr. Ben Jones had characterized the Ben Jones protein and then publish in that kind of journal. So this is the history of Ben Jones protein, which initially identified laboratory physician Thomas Watson. Okay, coming to the patient's history. Now the patient, because we want to look at what if there is skeletal involvement. So you can see the patient's skull. You can see the X-ray. There is a lytic lesion. You can see here. You can see here, and there is a vague lytic lesion here also. So there are multiple lytic lesions in this patient. Here, even the CT scan can show the lytic lesion here. So the bone marrow was done, and this is a bone marrow from the patient. Now, bone marrow, you can see clearly hypercellular bone marrow. You hardly see any fatty space here. So hypercellular bone marrow for this age of the patient. And you can see there are many plasma cells. If you see carefully, there are multiple plasma cells, sheets of plasma cells close to the marrow. And here you can see the groups and clusters of plasma cells. Definitely plasma cells are increased. There are, if you see carefully, there are some binucleated plasma cells. So let's take a closer look. You can see the plasma cells are increased, and some of the plasma cells also show prominent nucleoli. You can see the prominent nucleoli there, right? Some binucleated plasma cells, some binucleated, trinucleated plasma cells are also there. So this was the plasma cell. Morphologically, clearly plasma cells were increased. The sheets and cluster of plasma cells with some of the plasma cells showing prominent nucleoli, as well as binuclear, trinuclear plasma cells. So immunofiltering was performed by using flow cytometry. I am just going through few plots. Now the people or the students who have not seen flow cytometry, I'll just describe this plot. This is flow cytometry dot plot. This is called dot plot because we can see the dots there. Now each dot represents a cell. Okay. And if you look at here, we have two axes. One is y-axis, the other one is x-axis. The y-axis, you can see the label is there, which indicates the expression of protein on the y-axis. So this is CD38 and this is CD130. So that means that we can read CD138 expression on these dots, that means on these cells, on the x-axis, and we can read CD38 expression, that is expression of CD38 protein on the cells on the y-axis. Now, as you can see, this both axis has a scale from 0 to 10 raised to power 2, 10 raised to power 3. Okay, this is logical scale. Now, cells or the dots which are close to 0 are basically negative for that protein. So, if on y-axis, the cells which are falling close to 0 or less than, at least say these are negative for CD38, and cells which are falling close to 0 on x-axis, these are negative for CD130. So as you move away from 0 to positive, this indicates positive expression. So you can see there are blue cells, blue dots, which are above 10 raised to power 1. Okay, right, on logical scale, that means positive for CD38. In fact, it is strongly positive. And in the same way, when you look at the cells which are above 0, close to the 10 raised to power 1, above these gray dots, these are positive for CD130. So this is a simple reading of these dot plots. That means in this dot plot, we have blue cells which are positive for, strongly positive for CD38 and variably positive for CD138, which the CD138 is a specific marker for
Plasma cell.
plasma
Plasma
cells.
cell, multiple.
Perfect. So that means we are dealing with plasma cells. No other hematopoietic cell, means the hematological cell, is positive for CD138 other than plasma cell. Okay. So that means it's very specific marker for plasma cell. That means we are dealing with plasma cells. Okay. Now, what we look for the plasma cell, we want to differentiate plasma cells normal from abnormal, whether these are normal plasma cells or abnormal plasma. So normal plasma cells, as you can see here with few dots, they are positive for CD19, they are negative for CD56, usually. Okay, not always, usually. Sometimes even the normal plasma cells can express big or dim CD56 expression. So the CD19 is positive normal plasma cell, CD56 usually negative. The other markers which are abnormal in plasma cells, in normal plasma cells, CD27 is strongly expressed and CD81 is also strongly expressed. You can see here. You can see here, these are normal plasma cells which are strongly expressed CD27 and CD20. An abnormal plasma cell here shows loss of CD27 and loss of CD18. These are normal plasma cells which are showing 19 positive and 56 negative. And similarly, the normal plasma cells do not express CD28 or 117. So abnormal plasma cells express both CD28 and CD117. Okay. So expression of CD28 and 117 or 117 is abnormal. Loss of CD19, expression of CD56 is abnormal. Loss of CD19 is abnormal. Loss of CD27 is abnormal, and loss of CD81 is abnormal. So we look at multiple markers because now neither of all these abnormalities is only one or two abnormalities are not enough to call plasma cell as an abnormal, because even normal plasma cells can show weak expression or down regulation of CD19. Okay, that means loss of CD19 not always abnormal. A subset of plasma cell usually shows down regulation or loss of CD19. The same way, a small subset of normal plasma cell can also show CD56, weak CD56. The same way, loss of a normal plasma cell, a small subset of normal plasma cells can show down regulation of 27 as well as 81. Right? But the combination of all these markers only can be seen in abnormal plasma cell. And the same way, this 117 and CD28 expression is only seen in abnormal plasma cell. The problem is that only a subset small, like 30% of cases of plasma cells will show either 28 or 117 expression. That means in rest of the plasma cell, you have to add all these markers. In addition to that, you have to also add light chain expression to study clonality, and this is called this is kappa and lambda light chain. So you can see the normal plasma cell shows both polyclonal kappa and lambda, but abnormal plasma cells are showing only kappa restriction. And when if you identify abnormal plasma cell with using this combination of this marker properly, then you will see more than 9 times plasma cell restriction. That means the ratio of light chain restriction will be more than 9, not traditionally believed 4:1. Okay, not 3:1. So that is this is the expression of this. Now it is important. Sometimes the patient with chronic inflammation or the chronic diseases like leishmaniasis, you can have increased plasma cell. The patient can present with backache, and so just because the plasma cell increase and just because the patient has anemia and backache doesn't mean that patient has myeloma. You have to confirm either you to study by using biochemical parameters, especially immunofixation and serum protein electrophoresis, or by using flow cytometry to confirm the abnormal plasma cell. Okay. This is a patient's bone marrow biopsy. You can see the bone marrow biopsy also have many plasma cells distributed. In fact, hypercellular bone marrow with increased plasma cells. And you can see on IC CD138 sheets of plasma cells in the biopsy. So let's summarize this case. So we have a 46-year-old male patient presented with backache, weakness, anemia, globulin levels were increased, serum, urine, and creatine levels were increased, indicating compromised renal function test, renal function. Then high levels of the IgG, kappa, M protein, urine, kappa light chain in urine, lytic lesions on skull, right? And in bone marrow aspect, we had 46% clonal plasma cells, and bone marrow biopsy had sheets of plasma cells. Now, the further we need to do the risk stratification, and the genomic risk stratification is important in addition to the other risk stratification system called the international staging system. Okay, that is called the ISS staging, which is a combination of globulin and beta 2 microglobulin levels. Okay. Here you can see in this patient we do not have any abnormality on cytogenetics. So the diagnosis of multiple myeloma was confirmed because we had crab features, right? We also had increased plasma cells, sheets of plasma cells. Now let's discuss one interesting fact of multiple myeloma. How the name multiple myeloma was coined first. You see, the multiple myeloma, the term was coined first in the history was coined by the Rustinsky, okay, from basically Ukraine, now myeloma, and Ukraine, that time it was Soviet Union, Russia, but now it's the part of Ukraine from the Kiev. Now, the myeloma word, basically myeloma is a Greek term which indicates tumor of marrow cells, which is arising from the marrow. And since the first patient which they identified, with the help of which the term was coined, was a 47-year gentleman, and they found multiple such lesions on autopsy. There were 8 separate tumors in the patient. They had a soft consistency and reddish in color were found. So because the myeloma means the marrow from the Greek word, and from the marrow, tumor of marrow, there were multiple tumors. That's how the multiple myeloma term was coined in 1873. Okay. So as I mentioned, let's discuss. So it's a genetically heterogeneous disease. There are multiple genetic abnormalities. You can read in detail. It's a B cell neoplasm. It's a clonal proliferation of plasma cell and produces monoclonal M protein. Normally, a normal healthy person do not show any M protein. M protein is not detected in a normal person. Remember, M protein is always abnormal. Okay. Now, this M protein, because there is a secretion of abnormal protein, this M protein gets deposited in multiple organs, leading to the end organ damage, which results in the clinical manifestation of multiple myeloma, which include, of course, hypercalcemia. So C comes from the hypercalcemia. Then renal insufficiency R, anemia A, and bony lesions. We have seen that there is pathological lesions, fractures, and which constitute the synonym of crab, which we all are aware of. Now, a few years back, now almost 12 years back, the further it is, this diagnostic criteria of multiple myeloma was further refined by the International Myeloma Working Group, which is very active group, and which included additional features to that, which include in addition to hypercalcemia, renal insufficiency, anemia, and bony lesion. In addition to that, they have included 3 more criteria. The one criteria is if the bone marrow plasma cells has more than 60%. Okay, so then if you have a ratio of involved to uninvolved serum free light chain is more than 100. In this patient, it was somewhere 22. Okay. And if we have seen more than one lesion, not one, more than one lesion of focal lesion of lighting lesion on MRI study. So these are 3 additional myeloma defining. So CRAB are the myeloma defining criteria. In addition to that, these are 3 more myeloma defining criteria. So if you have 60% plasma cells, light chain ratio more than 100, involved light chain, and a focal lesion in MRI. So it constitutes another synonym, another acronym basically of SLIM. So it becomes SLIM CRAB, right? So this is and additionally, you have to remember when you are considering this criteria, there has to be presence of more than 10% clonal plasma cells in the bone marrow. And it mentioned clonal plasma cells. So you have just 10% plasma is not enough. You have to confirm they are clonal. So these are the criteria for the plasma multiple myeloma. Okay. Now, one interesting fact of this plasma cell. Anybody can anyone recognize this image? Probably some of the textbooks they have this image. Okay, if you read big textbook, probably that will have your this image. But this is the image of a patient called Sarah Newberry. This is the patient's name, which is there published, because this was the patient who is very popular in the history of myeloma, which had these multiple bony lesions leading to this limb abnormalities. This patient was 39-year-old lady, and this was the first reported patient of multiple myeloma by Dr. Samuel Soli from the Guy's Hospital, and they called it molluscum osseum, basically. That time the multiple myeloma was not the term. The multiple myeloma term was defined later on, but the mollitis ostium was the given because it has multiple lighting lesion in the bony lesion, in the multiple lighting in the bone lesions in the bone. Okay, so that was about the case 1. Any comments or anything, Dr. Neeraj? Neeraj, if you want to add anything about this myeloma case, or if any student have any question or comment, we can discuss.
Yes, sir. Sir, there are a few questions in the chat box. Should I ask now or after the talk?
Yeah, I think case by case we can take. Would that be right, Neeraj?
Yeah, please. Yes,
Yeah.
absolutely.
Okay. So the first question is when to consider positive in dot plot above 0 or above 10 power 0.
Sorry. Yeah. So the dot plots, okay, dot plots from. So this scale is little arbitrary, okay, but usually general understanding is saying the events which are less than 10 to the power 0, which means actually 1, is considered negative, okay. But laboratory can decide where their 0 falls, okay. Usually it is between 0 to 10 raised to power 0. The 10 raised to power 0 is 1. So those events are considered negative. Okay. But you have to always compare any negative expression with internal negative control. Because sometimes with the flow cytometer setting that the negative population can shift even above 10 raised to power 0. Okay. So, but yes, this is how we interpret the dot plot.
Okay, sir. So the next question is in a bone marrow aspirate of suspected myeloma, which cells are positive for CD38 and CD138 other than the plasma cells?
Okay, so CD38, yes. So there are many cells which are positive in CD38. So usually CD38 is expressed because it's adhesion molecule is expressed in many other cells, including blasts, hematobones, then the monocytes, activated T cell, naive B cells. Yeah, CD38 expressed. But the level of CD38 expression in plasma cells is stronger than the other cells. Usually, the CD38 is weak or moderately expressed in other cells, but plasma cells is strong. For CD138, CD138 is only expressed by plasma cells in hematopoietic cells. It can be expressed in non-hematopoietic cells, but in hematopoietic cells, only plasma cells express CD138. During flow cytometric analysis, you have to be careful because you can have some non-specific binding. That means the antibody just bind even in the absence of CD138 antigen on the cells. That is called non-specific binding. So it can be expressed non-specifically to the other cell, but specific expression of CD138 in hematopoietic cells is only present in plasma cells.
Yes, sir. So next question is what will be the internal controls for CD81, CD27, CD56 and CD117 in bone marrow aspirate?
Okay. So CD117 is expressed in myeloid blast. Mast cell it is strongly expressed. Then even the precursors of erythroid cells, promyelocytes, they express CD117. Okay, that's your internal positive control, and of course the remaining cells will be internal negative control. Like T cell, B cell, monocytes, they're internal negative control. For 56, NK cell is because NK cell express CD56, so that will be your positive control, and rest of the B cell, T cell, granulocytes will be negative control. For CD81, again, CD81 has multiple markers. So CD81 internal positive control will be hematopoiesis. So the normal B cell precursor express CD81 moderately, strongly. Even mesenchymal stromal cells express CD81. Even basophils express CD81. So those will be your internal control. The remaining cells, the majority of the T cell will be negative for CD81. Monocytes will be negative for CD81. And coming to 27, now 27 is expressed in the B cells. So usually memory B cells express CD27. Okay, and naive B cells are CD27 negative. So that is your internal positive and negative control. Even memory T cells express CD27. A subset of naive T cells express CD27. So multiple cells subset, not wholly, but a subset of B cell, T cell express CD27 as a control, and the same cells like the effector cells will be negative for CD27. So you can use these cells as a control. So always you have internal control for these markers.
Okay, so the last question is what kappa lambda ratio required in flow to term monoclonal?
Okay, so that is an interesting question because see, traditionally we believe the normal ratio is 3:1. Okay, so anything which is more than 4:1. But you know, sometimes even the benign proliferation can lead to this ratio. So if you add nowadays, because this question comes for the flow cytometry, I understand. But in flow cytometry, if you have the usually now we use at least 8 to more than 8 color of flow cytometry. So you have to put a marker in such a way that you have to use additional markers in addition to kappa and lambda, so that you can identify the target population. In this myeloma, we say CD19, 45, 56, 27, 81. And if you identify the population properly, you will always get a ratio of more than 9:2. Always get. Okay. Unless and until if your gating is not proper, then your ratio will go down. So I would recommend and prefer 9:1 ratio to identify or to define the clonality in properly gated cells.
Okay, sir.
Even for
Here's one more question. What could be the panel of markers for a 10-color flow cytometry for diagnosis and for MRD in plasma cell disorder?
okay, 10 color. Yeah, so 10 color you can. I have mentioned those. If you start with 38, 138, you will have 2 markers. Then you have 19, 56, 27, 81. More 4 more, so that will be 6 marker. You have kappa and lambda cytoplasmic, that will be your 8 markers. And if you can add 28, 117, you can add. We usually use 20 and 117 instead of 28. So 20 and 117 are helpful marker for the identification of this plasma cell neoplasm. So this is the optimum 10 color panel where you can add 8 plus 2 marker 2, that is light chain for 2, and the 2 markers for gating, 2 markers for clonality, and the 6 markers for identification of abnormal plasma.
Okay, thank you, sir.
Sir,
Okay,
I also have a doubt.
Yeah.
So there were two like in the SLIM criteria, it's mentioned that more than 60% of plasma cells are required.
Right.
And then we said that for confirming more than 10% of biopsy proven plasma cells are needed. So, sir, दोनों criteria.
No. So more than 10% is not disease defining criteria. See, when you have out of slim crab, you have any criteria. So you have more than 60% plasma cell, or free light chain ratio more than 100, or lighting lesion on MRI, more than one lighting lesion on MRI, or crab criteria like hypercalcemia, renal insufficiency, anemia, bony lesion, bony fracture. If you have these criteria, when you have this type of abnormalities or findings, in that case you have to have at least minimum 10% of plasma cells in bone marrow. The reason is because you can have anemia and you can have 5% plasma cells. The anemia may not be related to your plasma cell neoplasm. So that in that case you should not end up calling it multiple myeloma. That's fine. But if you do not see any crab criteria, let's say out of crab 4 criteria you do not see anything, but you have 60% plasma cells which are clonal in bone marrow, you can straightforward call it multiple myeloma even in the absence of crab criteria. So that is why the 60% plasma cell is the disease defining criteria for multiple myeloma. 10% plasma cell is the requirement, basic requirement. It's not disease defining, it's a requirement when you have other features of myeloma defining criteria.
Thank you, sir.
Okay. So I think the case 2 will be discussed by Dr. Neeraj. So I will hand over the PPT to the Dr. Neeraj.
So
Yeah, Neeraj.
Prashant, you will have to move this
Yeah.
a little bit. Yeah. So next slide, please. So this is case 2, and what Prashant has done is he has touched upon the multiple myeloma part and explained the various criterias. So moving further, so this was a 83-year-old male who presented over the last year with abdominal distension, weakness, low hemoglobin, and was taking ATD for 3 months. And on examination, he was afebrile. There was right cervical nodes were there and they were matted, and even there were bilateral axillary nodes 3 to 4 centimeter were there. And on examination, there was no organomegaly and there was tenderness over the spine. Next slide, Prashant. So you will have to move the slide, Prashant. You will. Yeah. So on radiological evaluation, so on the ultrasound, we had focal hypoechoic lesions in the liver. There was splenomegaly. There was ascites and left hydronephrosis. And on the MRI, there was compression, collapse of C4 and C5 vertebra. And there were multiple discrete nodes showing necrosis on the MRI. Next slide. So the further lab investigation in addition to the radiological showed hemoglobin. These are routine investigations that we do whenever we are evaluating any cases. So which included the CBC, which the hemoglobin of 11.4, then TLC of 11 for 15,500 with normal distribution. The platelet count was normal, so it was normal, and the total bilirubin was normal. The total protein was 7.4. The albumin was 1.5. The globulins of 5.9. SGOT 67, SGBT 49. Creatinine normal. Sodium 133. Potassium 5.1. Serum calcium was 7.6. Phosphorus was 2.5. And LDH of 572. Next slide. So you moved some of the slides. So based on this investigation and the presentation and the testing that was available, since this patient had lymph nodes, a lymph node biopsy was done. And as you can see in this node, there is loss of architecture. There is no, you're not able to see any routine follicles or the sinuses. So there is complete loss of architecture, and what we are able to see is a vaguely nodular kind of an infiltrate with loss of architecture. There are some fibrous bands and collagen septis making ill-defined nodules. And when you go on high power, you have a look at this, what type of cells are there. You see a polymorphous infiltrate, inflammatory infiltrate, where you have lymphocyte, plasma cells, occasionally eosinophil, and there are some large cells with eosinophilic prominent nucleoli looking like a Hodgkin cells. So based on the morphology of these the lymph node, you suspect that this is likely a Hodgkin lymphoma, right? So whenever we are suspecting Hodgkin lymphoma, the primary panel we tend to include, which includes 320 and CD30. And when we did that markers, we see that there is CD30 positivity and a very typical Golgi membranous zone positivity in these large cells. So this Hodgkin-like cells are showing very nice CD30 positivity, and these large cells on PAX5, you see a slightly weaker PAX5 as opposed to some of the strong CD20 or PAX5 cells here. So as compared to these cells, slightly weaker expression of this large CD30 positive cells. Next slide. So I think some of the slides are not there. I think. So basically,
let me check it while there is.
No problem. I can. Okay.
I'm just getting started.
Yeah. So I think some slides are not there.
There's something. Okay. Yeah.
Okay. So anyway, so some of the so the background. If you can go back, I just need to explain the slides here. So basically, the morphology had a nodular infiltrate with some large cells, Hodgkin-like cells, and Hodgkin lymphoma was suspected. So whenever you suspect such a morphology, you have a initial panel which go with CD3, 20 and CD30. And in this case, CD30 was positive, CD3 highlighted the background T cells, and CD20 was negative. And then the further markers like PAX5, OCT2, BOB1 are done to be able to CD45. Those markers are additional done to see that whether we are dealing with a Hodgkin lymphoma. And there is weak PAX5. There was 45 was negative, though I'm not able to show in the slide here, but 45 was negative, and OCT2 BOB1 was also negative. So in this, we are able to say that this is a case of Hodgkin lymphoma, classical Hodgkin lymphoma. That was the diagnosis given here. And I think some more slides are missing. Can I show my slides, Prashant, here? I'll just take off.
Okay.
It doesn't complete the.
No, the slides are there, but it's not showing.
Maybe you can just move a little bit.
Yeah, it's there, but shall I show like this? Because you can see like this without
Okay.
presentation mode. In presentation mode, they are missing.
So maybe just you can. I will share some slides for this case.
Okay, shall I stop then sharing?
Yeah, please stop sharing. Then I will share. I will share some.
Stop.
I'm not able to share that. Can you see my slides?
Yeah, put in the presentation mode.
Sorry. Are you able to see that?
Yes, sir.
Yes.
Okay.
Maybe I have modified this presentation for something else.
No problem. No problem. See, I'm not able to complete the case. So these are some of the slides I needed to show. So this is CD3. You can see 30 positivity and 45 is negative. You are able to make out here 45. Yeah, you're able to make out. Okay. So these with this immunophenotype, you know that this is a classical Hodgkin lymphoma, and parallelly the bone marrow staging bone marrow biopsy was done. And are you able to hear me now?
Yes. Yeah, clearly.
Yes. Okay. So this bone marrow biopsy, you can see here an infiltrate. This is a hypercellular bone marrow, and you see some infiltrate in the bone marrow biopsy. So whenever we diagnose Hodgkin lymphoma, parallel staging marrow is done. And on this biopsy, bone marrow biopsy, you see an infiltrate where there are predominantly small cells, and there are scattered plasma cells, and some large cells are there. And on further characterization of these cells, you see CD3, kind of a nodule of CD3, and some of the large cells are showing CD30 positivity. So now in a case of Hodgkin lymphoma, with this kind of a nodule or infiltrate in the bone marrow showing CD3 and 30 positivity, you know that you are dealing with the Hodgkin involving the bone marrow. And this happens around 5 to 10% of the cases of Hodgkin, where you are able to see an infiltrate and Hodgkin cells. Now, what was interesting here was, so this is a normal. So one of my colleagues saw a the lymph node, and I saw the bone marrow biopsy and the aspirate. But there was a call from my clinical fellows who said that you are giving a diagnosis of Hodgkin lymphoma. You have not checked the paraproteins, and here as Prashant showed in the previous slide, we got back and saw the protein electrophoresis. There was a moderate M spike of 3.1 grams in the gamma region. So this patient had a moderate M spike, and on characterization, immunofixation, it was IgG. So IgG was very high in here. So this was entirely missed out. So usually whenever Hodgkin is there, the bone marrow shows some plasma cells. This is predominantly reactive kind of a plasma cells, and we tend to ignore those plasma cells, and we leave it like that. We do not characterize in a staging kind of a scenarios. But here we knew that there is a Hodgkin lymphoma, there is a bone marrow involvement is there, and there is increase in plasma cells, which morphologically were there. But in addition, there was protein, there was an M band, and IgG was increased. So we needed to characterize those plasma cells. And Prashant previously showed a flow cytometry characterization of those plasma cells. So we have to go back to the biopsy, and this is a high power view showing there were focal aggregates of plasma cells, and when we need to demonstrate it on the biopsy, as in flow, you have various markers, and this is CD138 in the bone marrow biopsy, showing the plasma cells infiltrate around 15 to 20% of the plasma cells were there. But whether this is reactive or clonal, we need to demonstrate clonality, and usually on an IHC, we do kappa and lambda immunostains, and you see that these are lambda restricted, and kappa is negative. So the lambda restricted plasma cells were there in that marrow, which we had initially missed out. As in flow cytometry, the 56 was positive. So this is an aberrant expression of plasma cells in this stain. Thereby again showing that these plasma cells which were there in this were clonal. So we had a diagnosis of classical Hodgkin lymphoma with plasma cell neoplasm, and this was retrospectively picked up based on the presence of paraproteinemia. So here again, as in many other cases, the history becomes very, very critical. The investigation becomes very, very critical. Paying attention to those abnormal cells is very, very critical, and then only you are able to characterize. Now, further characterization of those plasma cells, you want to know what type of plasma cell neoplasm you are dealing with. So to summarize those findings, so here there were no myeloma defining, no CRAB criteria, no SLIM criteria, but there were clonal plasma cells on the biopsy, which is around 15 to 20%. So fitting the clonal plasma cell more than 10%, and an M band which is more than 3 grams. No other markers related to plasma cell neoplasms are present. So what we are dealing with is probably a smoldering or an asymptomatic plasma cell myeloma along with classical Hodgkin lymphoma. So this was this case. And when you define the smoldering myeloma further, so here both the criteria must be met here. So here the serum monoclonal proteins should be more than 3 grams, or urinary monoclonal protein should be more than 500 grams per 24 hours. And the clonal plasma cells in the bone marrow somewhere in the range of 10 to 60%. So anything above 60% would come in the criteria of the disease defining entity, and we will have to call it a myeloma. So somewhere in that 10 to 60% range below the disease defining event, and there are absence of myeloma defining events or amyloidosis. So both these criteria should be met to be able to label this case as a smoldering multiple myeloma. So these smoldering multiple myeloma, they have a risk of progression to multiple myeloma every 10% per year. So they progress to multiple myeloma around 10% per year. So this brings to the next question in this case. So we have seen a lot of markers being described. Which of the markers is specific for plasma cells. So you have CD38,
CD56.
CD138. So CD138 is indicating one is kind of the specific marker for the plasma cells. So we come to the case number 3, and I think Prashant.
Sir, here is one question in the chat box. Can I
Yeah,
ask?
please. Yeah.
Sir, clonal plasma cells. For clonal plasma cells, how can clonality be confirmed? Only on the immunophenotype?
So I think Prashant showed the ratio. So first is the abnormal plasma cell. So you have to kind of define the abnormal markers. You have to identify either gain or loss of markers on those plasma cells. So that is what flow cytometry allows you to do. So you are able to gate out your CD38, 138 and look for those normal and abnormal markers and see that whether those plasma cells are normal or abnormal. This is part 1. So second is clonality assessment, that the kappa and lambda chain restriction ratios. So that ratio, as I shared by Prashant, that ratio more than 9 is what you can be considered typically more in favor of a restriction, and saying that this is a clonal population we are dealing with, and this is likely to be a myeloma or smoldering myeloma or anything. When you are looking them on immunohistochemistry, sometimes the getting the ratios is difficult, so you have to have a rough estimate of those ratios, and then only you are able to take a call on accuracy, on saying with confidence that this is what you're dealing with is a clonal plasma cells, and sometimes aberrant expression of markers. So the positive markers that you are able to see on the IP, like CD56. So those are important markers when you are evaluating on a bone marrow biopsy to say that these are clonal plasma cells.
Okay, thank you, sir.
Yeah, in biopsy, you can use in situ hybridization also.
Yeah, so there is, so what I showed is a IHC, immunohistochemistry, where you have so there is another technique called in situ hybridization, which is sort of more accurate and allows in terms of clonality testing. That there is a technique that is called in situ hybridization, where same kappa lambda is there, but different technique, but the accuracy is very high. With standardization of the immunohistochemistry, kappa lambda is many a times challenged. So you're not able to standardize that with great effect. So in biopsy, if the gold standard is in situ hybridization, or ISH is gold standard, then comes IHC.
Yeah. So
Yes,
I realized, Neeraj, that I have opened actually wrong presentation. I think some minimized presentation. Now I opened right presentation. Yeah, because I had two presentations. So I think that was for the shorter duration. So I've opened this one. So I'm going to go little bit on the back on multiple myeloma regarding the prognostication. Yeah. I think that is scared.
I think MRD and all details were missed out. Some of the things were.
Yeah, so that's why I'm continuing with myeloma, prognostication and monitoring, because somehow I opened the wrong presentation in the same name. So so coming from smoldering myeloma again to the multiple myeloma, we have seen the diagnostic criteria. Let's look at the prognostication and how we monitor the myeloma patient. Now, for prognostication in multiple myeloma, there are multiple things. We can look at international staging system. So traditionally, for long years now, the ISS, that is international staging system, is used. Then another is the cytogenetics. So genomics is the another part where you look at the prognosticate high risk versus standard risk, and then LDH levels and flow cytometric immunophenotyping is there. So this is the international staging system. Now we do not use international staging, but because it has been revised, so that they call it the revised international staging. But the staging system include, the stage 1 include when you have beta 2 microglobulin levels less than 3.5 milligram per liter, and if you have serum albumin level more than 3.5 gram per deciliter. Okay, so albumin level is high and beta 2 microglobulin is low, then it is stage 1. And stage 3 is when you have beta 2 microglobulin is high. So when is stage 3? Irrespective of albumin level, if beta 2 microglobulin levels are high, more than 5.5 milligram per deciliter. This is called a stage 3. And the stage which is doesn't fall in stage 1 or stage 3, then it is called as a stage 2 ISS staging. Okay. Cytoplasmic, for the genetic stratification, now it is being revised, and there is something called as a deletion 1q or the amplification of 1q is included in this. But the standard high-risk cytogenetic is translocation 414 and 1416, and of course deletion 17p. Okay. You can look at, this is the frequency of different genetic abnormalities which is been published. This is the fish technique where you can look at, because one arm is deleted, so you can see there is only one signal from 17 chromosome P. The same way here, the 1q gain, which I mentioned, there is a 1q is gain. So you can see there are three signals. 1q is gain in fish. So 1q gain and amplification is also considered as a high-risk genetic. So in addition to 14 and 1416, 414, 1416, and deletion 17, that is to be 53 mutation, we have 1q gain. So these are four which are considered as high-risk cytogenetics. Okay, so you can see there is a fusion. When you have yellow color, that means the green and red is fused. So there are fusion of the chromosome, fusion of chromosome. This is considered as a abnormality. And this is again hyperdiploid. You can see there are multiple chromosomes at 2, 3, that level of 9, that level of 7, 14, 24, 17, 11. So you have multiple trisomies, and which indicates which contribute to the hyperdiploid. Hyperdiploid is a good prognostication marker. Generally, almost 60%, 50 to 60%, approximately half of the myeloma patient has hyperdiploid. Now, using currently the IMWG, the international, incorporated the cytogenetics, LDH level, and IS system, and it's made revised international staging system, because the old IS staging was not enough to risk stratify adequately. So they incorporated cytogenetics as well as LDH and revised IS staging. Currently, we use revised IS staging system for classifying the risk stratification of multiple myeloma. So what we do here, we incorporate these things. So if we take ISS stage 1 and any standard risk fish, that is cytogenetics, and normal LDH level is categorized as revised ISS stage 1. Okay. So revised ISS stage 1 includes ISS stage 1 and standard risk cytogenetics and normal LDH level. Revised ISS stage 3 include ISS stage 3, and either you have high risk cytogenetics or high LDH level. So that compromise that contribute to revise ISS stage 3, and anything which doesn't fit into stage 1 and 3 is basically revised ISS stage 2. Okay. So this was the data based on which they have come up with this risk stratification system. And 1q, as I mentioned, 1q gain is added to the high risk genetics of this high risk cytogenetics. Okay. Now, other parameters of prognostication also include flow cytometric data, which indicates the expression of 117 indicates good prognosis. Expression of 28 indicates poor prognosis. So combination of 28 and 117, that is 117 negative and 28 positive, also indicates poor risk factor. Again, CD19 positive. CD19 usually is negative, but approximately 2-3% of multiple myeloma patient can have CD19 expression, which also indicates poor prognosis. The same way CD81 expression also indicates towards poor prognosis. Then I mentioned hyperdiploidy, hyperdiploidy or higher DNA index also indicates good prognosis. Then proliferation rate. So when you have more proliferation rate, especially more than 2 or 3% proliferation rate, when you have plasma cell cycle and you have plasma cell in S phase or proliferating plasma cells more than 2 or now considered even 3, also is associated with poor risk. Okay. Now there is another feature called MGUS-like immune signature, where you have immunophenotype look like MGUS. Basically, when you have more than 10% of normal plasma cells. So if you have more than 90% of clonal plasma cells and less than 10% of normal plasma cell in bone marrow, that is closely correlate with MGUS-like signature. And a patient with MGUS-like signature has very good outcome. And another upcoming strongest the prognostic factor is circulating plasma cell at the time of diagnosis. If you have circulating plasma cell at the time of diagnosis more than 0.01%, it is high risk multiple myeloma. I am hoping in recent future, that is next 2-3 years, there will be next version of revised, that is R2 ISS staging, which will include circulating plasma cell as a part of prognostication. Just to show you, we can do ploidy by using flow cytometry. We look at the S phase also. You can see that we can look at S phase of tumor and we can identify that proliferating plasma cell. And we can look at also DNA ploidy of this. I'm not going to this ploidy because otherwise it will take longer time for the for covering our topic. Now, most important and reliable prognostic factor of any disease in hematological neoplasm is measurable residual disease, which indicates that if you have a tumor after induction therapy. So after initial therapy, like in acute leukemia, post-induction therapy, similarly, after initial therapy in myeloma, that is post-induction therapy, either at the end of 4 cycles of chemotherapy or in patients with transplant or in patients who are not going for transplant at the end of 8 cycle, we assess for the residual disease. Residual disease represent the cells which are still there, remnant of the tumor cells after initial intensive therapy. And if you have that residual disease, it is highly correlative or highly predictive of relapse in a disease or progression in multiple myeloma. So if you want to see identify high-risk disease, that is the disease which has high chance of relapse or progression, the MRD monitoring is most important. And here you can see these are the plasma cells which are indicated by olive green with CD38, 138, and another additional plasma cell marker is CD319, which can identify plasma cells. This is a SLAM protein. And you can see out of these plasma cells, so there are only 0.05% plasma cells. Out of them, only 20 plasma cells which are CD19 negative, CD56 positive. They are showing so partial loss of CD55, and there is no CD117 or 200 in this. But you can see almost all these plasma cells are clonal, showing the kappa restriction. Only one dot is lambda, which confirms these are clonal abnormal plasma cells at very low level. Here we acquired almost 4.5 million cells, so 20 in 4.5 million cells. You can see the level of MRD was 0.0004%. So okay, so in this patient was multiple myeloma with our revised ISS stage 2, that is intermediate. Okay, so that was about myeloma prognostication. Let's move case 3. Now this you have all your slides here.
Sir, here's one question in the chat box. Can I?
Yeah.
Sir, question is which method do you recommend for plasma cell enrichment for fish analysis?
Okay, so there is bead based, you can have used magnetic bead based enrichment. So usually there are two types of, one is column based and one is magnet based. So in column also there is a magnet. So column is expensive. So usually we have seen using the magnet based immune bead based enrichment. So basically you have beads which has CD138 antibody attached to it, and these beads are you can concentrate the beads using a magnet, so that only magnet will CD138 positive cells only will be stick to the magnet, and rest of the cells will you can see. So you can enrich the plasma cell by using immunomagnetic method using beads positive for CD138. And approximately you can get pretty much good purity, or more than 80% purity in most of the cases, in diagnostic cases. So that is being used in our department, in our cytogen department also they use the same method. The other method is column, but which is very expensive method. Okay, so coming to the case 3, this is 63-year male patient.
So one point.
Yeah.
Just I wanted to highlight that whenever you are
Yeah,
using fish testing, so please, you always have to use CD138 enriched plasma cell for any fish analysis. You do not use your direct sample for, you don't use direct and test. If you are using direct sample for your testing, the chances of picking up abnormalities is far less. So if I'm using direct without any fish enrichment, my chances of picking up the abnormalities, high risk abnormalities in the range of 30-40%. But if I'm using magnetic bead this sample and then testing for my fish analysis, my chances of picking up abnormalities goes in the range of 80%. Okay, so always we have to use 138 enriched sample for my fish testing to be able to fully risk stratify my myeloma sample. Yes, please, Prashant.
and now there are advanced genomic methods are available for evaluation the genetic abnormality. Although they are under trial and evaluation and expensive, but yeah. So for fish, as Neerajan mentioned, you have to, especially when you have because many times in bone marrow aspirate, you get less number of plasma cells. You know, the percentage of plasma cells in aspirate usually is low when you collect the sample for fish. Okay, so let's go to the case 3. This is 63-year patient again, retired worker, presented with headache, vomiting, imbalance while walking, vertigo, hearing. Look like the central nervous system abnormal features because headache, vomiting, imbalance in walking, vertigo, hearing impairment, the decreased vision. Okay, and history of but there was no history of seizures or any trauma. Now the patient was, of course, investigated for CNS symptoms. The brain MRI was done. No abnormality was detected. Then MRI spine was done. They showed the disc bulges at C4, C5 level, C5, 6 and C7 level. Also L4 and L5 level. The CT and MRI brain suggestive of generalized mild cerebral atrophy is there. With the age can be okay. With chronic ischemic changes. Now, X-ray was done, and X-ray showed the cervical lytic lesion as C3 vertebra. So, okay, there was lytic lesion in C3 vertebra. So the patient presented with CNS symptoms. MRI was brain did not show anything. CTA, the spine had few abnormalities, and lytic lesion in X. Okay. Now this was the patient at the time of pandemic, the COVID-19 pandemic. I think in year 2022. So HRCT was done in this patient, and the HRCT chest had shown a lesion, 3.6 centimeter dense lesion in the base of right lung. And the hemoglobin was done. CBC was done in this patient, and you can see the hemoglobin looks pretty normal, close to normal at least. Slightly maybe lower than platelet looks normal. In fact, up to the higher normal, more than the usual range. Then WBC count looks normal. So CBC parameter looks pretty normal in this patient. The biochemical parameters also, looks okay. Creatinine looks normal. Urea levels looks normal. So yeah. And this patient, because there was lytic lesion in the cervical, so the serum electrophoresis was done. And you can see the serum electrophoresis, there is a band. Instead of gamma, you can see the band in the beta region. Band in the beta region, overlapping slide partly into the gamma region. And so M protein was detected with 1.3 gram per deciliter. Okay. And on nephrometry, we can see there was, if you look at it carefully, the Ig levels are increased than the normal range, because IgM and IgG level looks normal within the reference range, and here you can see the lambda light chain was increased. Even for free light chain, lambda light chain was increased. The ratio was 0.1, or if you look at the ratio of involved to uninvolved light chain is 10. Okay, these were the abnormalities. So bone marrow was done in this patient to look at if there is increase in the plasma cells. You can see in the bone marrow was not hypercellular, but it was normocellular. You can see that some few plasma cells were there, but scattered plasma cells are there. but doesn't look like they're more than 10%, looks like less than 10%. This is higher picture, you can see the plasma cell one or. So, okay, so, and the flow cytometry was done in this patient. You can see there were the plasma cells, as we had discussed earlier, CD138, 38 positive, 1%, 0.1% plasma cells were there. And out of 0.1%, approximately 72% shows abnormality, which is indicated by orange color here. You can see there are 90 negative, 56 positive, 21 is positive in this case, not lost. CD81 is weak, but you can see the CD128 is positive and 117 is positive, indicating the abnormal expression of 27 and 117, loss of 19 and 56 aberrant expression, and they were clonal. You can see the ratio is 98 as to 2% or 1.3%. You can see that means almost 90 more than 45% of the ratio. 45 ratio is more than 45. And the normal plasma cells, the remaining 30 or 28% plasma cells were pretty polyclonal. Right. Okay. So this was that confirms there are a subset of plasma cells that approximately 70% plasma cells. They're clonal and abnormal. The bone marrow biopsy was done. Bone marrow biopsy, you can see it's a normal cellular bone marrow biopsy. On this view, with this, I don't think so we can appreciate plasma cell. The plasma cell is there. Let's say the closer view, you can see in closer view there is occasional scattered plasma cells are there. Here, you can see one here. You can see one here. So IHC was done. IHC shows scattered few small clusters. I don't think so. I think on biopsy you can consider plasma cells are there, but it looks like less than 10%. Okay, so meanwhile you know that this was the lesion. Meanwhile, the biopsy from the lung lesion was done, and it was the report came out from this. You can see this lesion, and it turned out to be adenocarcinoma of the lung. Okay, so there was an adenocarcinoma of lung in the biopsy. So we had few plasma cells. There was M protein detected. Free light chain ratio was abnormal. Was also abnormal. But the plasma cell percentage was less than 10%. We had seen lighting lesion, but at the same time we have also noted the patient had lung lesion, and that lung lesion turned out to be adenocarcinoma. The patient also has CNS symptoms, remember. So the CSF was done, and in CSF you can see there were signet ring cells were there, which indicate that basically there was metastasis in CSF as well as in the vertebral lesion creating the lytic lesion in vertebra, and that's why the patient has CNS symptoms. Okay, the CNS features of involvement of CNS because of metastasis. So the final diagnosis of this patient was adenocarcinoma of lung with metastasis in the vertebra as well as the CSF. And there was associated plasma cell neoplasm. Let's summarize the plasma cell neoplasm findings related to plasma cell neoplasm here. Okay, there is no evidence of myeloma defining lesion in this because you can see there was no crab lesion other than that lytic lesion which is associated with metastasis, but otherwise the renal functions were normal. There was no anemia and the calcium levels were normal. Then the plasma cells were less than 10%. M protein level was also less than 3 gram per deciliter. So this was case of MGUS, non-IgM type of MGUS, because MGUS is also classified as IgM and non-IgM. The IgM type of MGUS comes under the part of Waldenstrom microglobulinemia, MGUS related to Waldenstrom microglobulinemia. But here you can see this was a patient of MGUS which was detected incidentally in a patient of adenocarcinoma. Now this is the classification and definition of MGUS. You can see the non-IgM MGUS, non-IgM MGUS is defined with serum monoclonal protein less than 30 gram, clonal. You have to remember this is a clonal bone marrow plasma cells less than 10%. That means you have to establish the clonality when you're looking at the plasma cells. And absence of end organ damage defining criteria for the CRAB. or amyloidosis like hypercalcemia, renal insufficiency, anemia, and bone. Now coming to the IgM type of MGUS, IgM type of MGUS include again the similar features. Only thing the monoclonal protein involved is IgM type. And then third category is light chain MGUS. So because we know that myeloma also can be defined into the light chain myeloma and light chain myeloma also. The patient, sometimes myeloma patient present without M protein or very low level of M protein, and approximately 20 to 30% plasma cells, approximately 15 to 20% plasma cells can present with light chain myeloma. Okay. So where you do not have M protein, or even if the M protein is there, it is very low level M protein. But there is sufficiently high light chain, which is more than 100 ratio of free light chain ratio. So for the in correlation with that light chain myeloma, you can also have light chain MGUS, where you have abnormal free light chain ratio. This is normal range of free light chain, that is ranging from 0.26. This is a ratio, free light chain ratio, to 1.65. Okay, in this light chain MGUS, you have increased light chain, but the ratio is more than either the ratio is more than 0.56 or less than 0.26. But no other features of a crab or slim crab. And of course, in addition to that, you have to also look at the urine monoclonal protein. It should be less than 500 milligram in 24 hours urine. So just to look at the picture of how, because we have discussed MGUS, we have discussed Smoldering myeloma, we have discussed multiple myeloma. So we have myeloma, plasma cells which undergo, in the bone marrow as well as in lymph node, it undergo post-germinal class switching and somatic hypermutation. And something happened at that level which leads to formation of clonal plasma cells. But there is no other clinical feature, and the clonal plasma cell less than 10%, and that is the stage of MGUS. So this is MGUS stage. So after primary genetic lesion, something happens at the genetic level which leads to that. Now this MGUS, after a period of time, can also progress to the next stage. That's called as Smoldering myeloma. Here again, we have increase in the plasma cells more than 10%, but less than 30%. But we do not have myeloma defining lesion, that is slim crab, and this stage is called as Smoldering myeloma. And then, of course, the next stage is the full-blown multiple myeloma. Now, if you look at the progression rate of MGUS to multiple myeloma is 1% in a year. So, in 1 year, 1% of plasma cells, that is one patient with MGUS in a year can progress to multiple myeloma. But in Smoldering myeloma, it is 10%. So, if a patient has Smoldering myeloma, there are 10% of chances to progress to multiple myeloma in 1 year. So this is and usually the secondary genetic events must be contributes to this progression, like copy number abnormalities, DNA hypermethylation, acquired mutation, additional mutation, possibly considered responsible for it. So this is the the biology or the pathogenesis of progression of MGUS to plasma cell. And the last stage of plasma cell, the multiple myeloma, is plasma cell leukemia, where you have higher level of circulating plasma cells, which indicates aggressive and poor disease. Okay. So MGUS, look at the MGUS, in general population, if you take a general population overall, is the prevalence of MGUS is 3%. That means 3% of general population, especially old age population, have the incidence or prevalence of MGUS in 3% population. Now, as I already mentioned, the progression rate for the non-IgM MGUS is 1% per year. Progression rate of IgM MGUS to Waldenstrom macroglobulinemia is 1.5% per year, and progression rate of light chain MGUS to light chain myeloma is very low, that is 0.3% per year. In India, there is limited data. There is a hospital-based registry data is there available. General population data is not available in India. which indicate that in MGUS rate it is considered is lower in Indian population, at least in hospital registered data from AIMS is 1.4% as compared to the 3% in patient more than 40 years. So they have considered the patient more than 40 years. Possibly that might be the also reason that why it is lower. But if you look at 40 to 40 years, it is 0.8. 50 to 59 is 1. More than 60 years is 2.6, and more than 70 to 80 is 1.7. But this is biased data because this is hospital registered data. This is not general population data. Okay, so already mentioned, we have discussed this, already. Now there is a historical fact, but I am skipping this historical fact. But you have to remember, look at this person. This is anybody knows this person?
Everybody has to know about this person.
This is Robert Kyle. This is Robert Kyle. He's still alive. So recently, yeah. So recently, I think last year, he died. So this is Robert Kyle from the Mayo Clinic, and who has done a lot of work in plasma cell neoplasm, but the MGUS term was first time defined by Robert Kyle. So they have done general population study. They adapted, the Mayo Clinic adapted a village, and they did this study, and then natural history of MGUS and progression over a period of 20-30 years they have done. Okay, so coming to the case 4, do you want me to continue, Neeraj, or do you want to open your presentation? How is comfortable? Because now I think I have the original presentation.
Sir, I have a question.
Yeah.
Sir, in the last case on dotlet of kappa and lambda, there are some cells that is going beyond the 10 to power 0 on the kappa axis. Still, those are the clonal cells.
Okay, let me here.
Yes, sir. The last.
Yeah. So here you're talking about these cells,
Sir, second. So this is the last,
one. Yeah.
last one.
This one.
Just below this.
This one.
Lambda. Yes.
Yeah. Yeah. What was the question again? Can you ask? Yeah.
Sir, actually, here are some cells that's going beyond the 10 to the power 1 on the kappa axis.
See, that's what I'm saying. The 10 to the power 1 is arbitrary. You have to define your positive and negative expression based on the control. So you can see the plasma, normal plasma cells also going up in here. So you can take it as a control, the positive control. Or you can identify lymphocytes or other monocytes and look at there and you can put. Usually what we do, we take, now in this part I cannot show you, but we take usually the non-plasma cells as a negative control, and you put your like select say lymphocyte. We take lymphocyte and you put your gate on that basis, the negative light. So your lymphocyte should follow in the negative zone, and anything above the lymphocyte is your positive.
Okay. Thank you.
Let's go to the case. Neeraj, do you want to open your presentation or do you want me to continue? Neeraj.
So what I'm saying is that you can escape. I will share my 2 cases, right?
Yeah, sure.
Then you can finish them.
I think that this case is. I think this is my case only, so I'll continue with this. Okay, the case.
Okay.
Yeah.
So 6 and 7 are my cases.
Yeah, right. Okay, so let's go to the next case. Now this is a 54-year lady from Patna. The patient had swelling in the left side of the forehead, and for last 5 months. So swelling on the forehead for last 5 months. The patient had headache, vomiting, but no fatigue, no swelling elsewhere. Okay, only one swelling. The local laboratory has done the investigation, shown the CBC, hemoglobin was 10, so mild anemia, counts looks normal. There is some thrombocytopenia also there. The creatine level looks normal. So this was the X-ray. You can see there is a lesion here on the head. So the patient came to our hospital, and this is a CBC findings from Tata Hospital. You can see here the hemoglobin is slightly lower, 10.8. Platelet looks close to normal, mildly lower, but otherwise there is no abnormality. So biochemical investigation was done, and you can see the serum protein level is also slightly increased. Globulin levels are high, definitely high. Albumin levels is also mildly low, borderline. So the serum electrophoresis was done, and because the globulins level are high, and there was local lesion and some one single lytic lesion, the skull X-ray. So the patient serum electrophoresis was done, and you can see clearly there is a peak in the gamma region of serum electrophoresis. You can see the M protein was 2.8 gram, and on nephelometry you can see there was IgG levels were high. Again, the lambda light chain restriction was there. You can see the 3 light chain lambda was there. Okay, and almost 40 times the ratio of involved in uninvolved was 40. And this is, you can see this immunofixation shows the lambda light chain and IgG M protein. This is a biopsy from the tissue. You can see the biopsy shows clearly a monoclonal population. Yeah, the same size population. You can see there, including infiltrating to the muscle. This is muscle, and you can see the monotonous population present all over in the biopsy. This is closer view. You can see, you can at some place you can clearly look like plasmacytoid morphology. These cells at some places it is more obvious. And the immunohistochemistry was done. CD130, you can see CD130 positive in all cells there. And on this is just the IHC. You can see the kappa and lambda. You can see that some light chain restriction is there. Some lambda positive cells are there. And this is the issue of I just plain IHC. That's why in situ hybridization for light chain gives the better results. But still, you can appreciate there some of the cells are showing lambda light chain restriction. So bone marrow was done. In bone marrow, you can see there are few plasma cells are there. Here you can see the binucleated plasma cell. There are the binucleated plasma cells. So their plasma cells are increased. And flow cytometry was done. Here again we identify plasma cell by using CD38, 138. You can see the orange population indicate abnormal plasma cell, which shows CD19 negative expression, CD56 positive. Even the 45 is also negative. The 81 shows down regulation. 27 is completely negative. That is another abnormality. 28 positive, another abnormality. And they were all lambda light chain restricted, as we have seen. And you can see the ratio is 99.5. That means the ratio is 99:1. Okay. So we on plasmas on flow cytometry also we confirm there are abnormal clonal plasma cells there, but the level of plasma cell you can see is only 0.03%. Now bone marrow biopsy. To look at bone marrow biopsy, you can see the bone marrow biopsy looks pretty normal. Cellularity looks normal. You can see the spot megakaryocytes here. There are few mutilated few spread cells are also scattered. And on zoom on higher power, you can see the megakaryocytes are there, but you can see there are few scattered plasma cells are there. Here. There are two plasma cells. There is one more. There is one more, right? And IHC, you can see the CD138 shows plasma cells, scattered plasma cells, but definitely more than what we have seen in the MGUS case. So to summarize this findings, the 54-year lady presented with the lesion on forehead. Radiologically, the tumor in the skull. I don't know. The X-ray looks like more in the skull instead of forehead. But no other lytic lesion. Biochemistry, definitely globulin levels are higher than albumin level. There is M protein, and the biopsy showed plasmacytoma, because bone marrow we have seen the fits of plasma cells. with lambda light chain restriction. Bone marrow biopsy and aspirate both have clonal plasma cell, but they are less than 10%. So there is no definitive myeloma defining event. So this was a case of plasmacytoma with minimal bone marrow involvement. So when you have plasma cell less than 10% by flow and by flow cytometry and by aspirate, and there is a plasmacytoma. It's called a plasmacytoma with minimal bone marrow involvement. So if no bone marrow involvement, then it's just plain plasmacytoma, which can be solitary plasma, which is called a solitary plasmacytoma, which can be medullary, which can be extramedullary. So usually a medullary plasmacytoma is common. Less common is extramedullary plasmacytoma, which happens into the soft tissue. But when plasmacytoma present with bone marrow involvement, but less than 10% plasma cell, it is called as plasmacytoma with minimal bone marrow involvement, and it is very high risk of developing multiple myeloma. So this is the IMWG classification of solitary plasmacytoma versus solitary plasmacytoma with minimal bone marrow. So solitary plasmacytoma with more than 10% plasma cells. If you have more than 10% plasma cells, clonal plasma cell, then it becomes multiple myeloma. Okay. Solitary plasmacytoma with usually has 10% progression rate to progress to multiple myeloma within 3 years of period. And solitary plasmacytoma with minimal bone marrow involvement, which we have seen, the 60% rate to progress to multiple myeloma in 3 years. So you can see from 10% to 60%. That means this is very high risk. This is because the plasma cell already showing the systemic involvement of the bone marrow. This is 2000 recent WHO criteria, which indicates these are the criteria. So biopsy proven plasma cell neoplasm, either bony lesions or extramedullary site. No clonal B cells. That is, the B cells should be absent. Then on no other lesions on physical examination or radiological studies. You should not have any CRAB criteria and less than 10% clonal plasma cells. Okay, one of the interesting historical fact is this myeloma cells. Coming to the myeloma cell, you can see the myeloma cells. This is something. The evidence of appearance, microscopic appearance of myeloma cells was first shown or noted in the history by the John Darlington. The pronunciation is Darlimpal, but we call Darlim. This was a surgeon who had looked at the microscopy and made engravings in the wood, engraving showing that these are the plasma cells. Even the multinucleated plasma cells he has seen in the microscope, and this was the first documentation how plasma cells seen under the microscope. Okay. Okay, so coming to the case 5. Any question so far for plasmacytoma?
No, sir.
So PG student, any question related to plasmacytoma? I encourage Aishwarya, Guneet, another Aishwarya. No. If you have any question, because these are the little overlapping lesions. These lesions are overlapping. You have plasmacytoma. You have plasmacytoma with minimal bone marrow involvement. You have myeloma, which so many times even in clinical day-to-day clinical practice, these are challenging cases, because sometimes with inadequate investigation, you can define this disease in other cases. And something which I would like to mention is, if you have one plasmacytoma, it is plasmacytoma. But if you see more than 2 or 3 plasmacytoma, then it becomes multiple myeloma by current definition. But these are still very good. These patients, even though are categorized as multiple myeloma, their outcome is very good. They usually can be seen in younger adults compared to the myeloma, and we see a good number of cases, such cases which earlier it was called as a multiple plasmacytoma, but now it is categorized as myeloma. But this patient without bone marrow involvement, and this patient with even more than one plasmacytoma, the 2 or 3 plasmacytoma, may not have any bone marrow involvement, and this patient usually do very good after chemotherapy. So that was the fact of one of the fact related to plasma cell. Now let's go to the case 5. This is 35-year patient. Again, presented symptomatic for last 2 months, presented with dry cough, no easy fatigability, significant weight loss, 9 kg over a period of 6 months, but no issue of fever or bleeding. Now, local laboratory has done CBC, and there was clearly severe anemia, thrombocytopenia, and the count was high. You can see the count is 46,900, so it's very high count. The ESR was also high, and total protein and albumin levels, if you look at that, the total protein levels were high, and albumin levels close to the lower normal limit of what we define, but slightly lower. Okay. And serum calcium level is pretty high. Serum calcium level is normal, not high, sorry. And the urine, you can see the urine has albumin level. The light chain was not good. So this was the investigation done in the local hospital. This patient presented in Tata Hospital. You can see the hemoglobin was 7.9, so anemia was there. Platelet was thrombocytopenia is there, and WC count was 23,000, so clearly high. And if you look at the CBC, the large unstained plasma cells were increased. Okay, so large unstained cells that you see were higher in CBC finding. This is peripheral smear. So you can see in peripheral smear. What do you note in peripheral smear? Again, one of the PG students. Can you describe the gross low-level microscopy in this? What do you see? Aishwarya or Guneet?
So rouleau formation we can see.
Very good. One is rouleau formation. Okay. What else?
So in leukocytosis.
Yeah, leukocytosis. Yes, correct. Leukocytosis is there. Rouleau formation is there, and
In RBC,
thrombocytopenia.
yeah, possibly thrombocytopenia is there. Maybe we can go to the higher view and you can see. Now, can you what you can see now? This is the oil. What do you notice now?
So there are circulating plasma cells.
Very good. So you can see the WC count we had in CBC also there were LUCs, more probably 40%, which the cell counter couldn't define whether these are lymphocytes or monocytes. So they had atypical cells, and these were you can see here there are plasma cells. You can see the circulation basically they are plasma cells. You know, so in circulation the count was high because of circulating plasma cells, and these circulating plasma cells were approximately 40% of total WBC. So further investigation were done. As you can see, serum urea level was slightly high, uric acid level also slightly high, and creatine level was high. Albumin, as you said, the total protein is albumin is low, and globulin level very high, and even the LDH levels were high. You can see. Okay, so on serum electrophoresis, M protein was there, 7 gram per deciliter, and the heavy chain IgG were increased. IgG levels were 10,000. Lambda light chain restriction was there, and serum free light chain. You can see the lambda light chain there restricted. Serum increase free lambda light chain, and flow cytometry was done in peripheral blood. And in peripheral blood, you can see there we identified plasma cell again. We're using 38-138. We don't see normal plasma cells. The abnormal plasma cell, subset of abnormal cell, plasma cells shows 56, but the majority are 90 and 56, both negative, which usually see in plasma cells. Plasma cells usually can show the down regulation of 56, because again 56 is the antigen molecule. Here, other abnormalities we see CD81 is completely down-regulated, CD27 is partly down-regulated, 45 is CD45 is down-regulated, CD28 was positive, which is again high risk factor, and the subset of plasma cells shows CD117 expression. and they all are light chain restriction. Now you can see I have taken light chain level down because there was so high number of plasma cells, and the amount of antibody we added probably was not adequate. That's why part of the plasma cells showing negative expression. So when you are adding, because there were thousands of plasma cells present in the sample, and with high count and 40% plasma cells, so we do not account usually when we add the antibody. Usually the antibody is not titered for so large number of plasma cells in the sample. So in such cases, you can show some down regulation because of inadequate antibody present in the your antibody your cockpit. So the diagnosis was plasma cell leukemia. Now, as I mentioned, plasma cell leukemia, this is old terminology. You can see this is old feature of where we used to identify or classify the criteria for classification of plasma cell leukemia was more than 20% plasma cells out of total WBC, or absolute count more than 2,000 is considered. But now the modified the method is now in 2021 in Blood Cancer Journal, the IMWG is presented, published another paper which shows that the criteria changed to 5%. So if you have more than 5% plasma cells or more than 500 circulating plasma cells, we can it is defined as plasma cell leukemia. So current definition of plasma cell leukemia is circulating plasma cell more than 5% of total WBC and more than 500 of total WBC, absolute count of more than 500 per microliter. Now, important is that up to now, because they are 5% plasma cell, even they need flow cytometry is needed, because many times you can have circulating plasma cell, even chronic inflammatory, long-term inflammatory diseases, where you can see the circulating plasma cell. So you have to confirm by using flow cytometry these are abnormal clonal plasma cells. And this is the article I was talking about, which is published in Blood Cancer Journal in 2021 by the International Myeloma Working Group, which defines the plasma cell using 5% criteria. Okay, so there is a question for PG student or other people who are looking. We have discussed this. Now, can you tell what is the normal range for free serum free kappa and lambda light chain ratio?
Is
Sir, option A is
0.26 to 1.65.
Very good. So it is 0.26 to 1.65. The candidates who want to appear for DM exam or fellowship exam, this is one of the important questions can be asked in the exam. Okay, so this is the right answer. Now I think that case 6 and 7 will be covered by Dr. Neeraj. So I will stop the presentation and Neeraj can take over. Yeah, Neeraj.
You can see my slides now. So case 6. So this was a 60-year-old male, and who's been smoker for 10 years, presented with pedal edema and facial puffiness since last 2 years. There was a history of oliguria, and he came with a history of neck pain since 1 year and was being evaluated for renal failure. And the CBC showed anemia. The rest of the parameters was normal. In the biochemical parameters, you had blood urea 82, creatinine was 2.5, uric acid was 8.3, SUTPT normal, alkaline phosphatase was 158, albumin was 2.7, LDH 610, and calcium was 8.7. As mentioned, there was anemia and there was slight lymphocytosis in the peripheral blood. The urea was high, and the urea, creatinine, and the globulin was on the higher side. The rest of the parameters were normal, and yeah. So serum protein electrophoresis showed a monoclonal band in the gamma globin regions, and there was increase in IgG and kappa. The ratios were altered. The kappa lambda ratio was altered, and the urine total protein was 6,780 milligrams. So these were some of the findings that we had. So being evaluated for renal failure, abnormal parameters, and on bone marrow examination, this was the bone marrow aspirate. So this is slightly this was mildly hypercellular marrow, and you can see the scattered plasma cells. And these plasma cells on higher power, you are able to see some binucleate forms and uh, some clusters over here. So they appear slightly mildly increased. So flow cytometry was done, and you could see that these are on CD38, 138 gating. You could make out that these were abnormal. These were clonal, expressing CD56, CD117, and they were lambda restricted. So these plasma cells. So we have a renal failure, increase in plasma cells. Those are abnormal plasma cells. The aspirate, and when we look at the bone marrow biopsy, you see the some amorphous material lying in the bone marrow biopsy specimen. And further, and this is very important whenever we are dealing with any plasma cell neoplasm, it is always important to to look carefully for any amorphous material, any thickened blood vessels in the HED stain that we do. So this biopsy showed plasma cells and this amorphous material which looks pinkish, and this is the Congo red stain showing the pink amorphous extracellular material um, 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 being shown in the Congo red stain, and on the this Congo red is showing the apple green birefringence here. This is one area showing that apple green, and this is another area where in the same patient you in the renal biopsy you were able to see this apple green birefringence in the Congo red immunostain. So further investigations in terms of the cytogenetic risk stratification that we spoke of, done using the CD138 sorting. There are less number of plasma cells using magnetic bead-based enrichment, and further testing for cytogenetic did not show any abnormalities, the usual abnormalities that we test out for. So what we are dealing with is amyloidosis, and as per the International Myeloma Working Group criteria for the diagnosis of myeloma and amyloidosis, we need the presence of amyloid related involvement, and that is documented by the presence of the Congo red stain in any of the tissues. Usually, in such cases, the bone marrow aspirate helps you pick up the amorphous material, or the biopsy or the fat biopsy, where you are able to demonstrate the amorphous material in the thickened blood vessels. And using Congo red or additional stains like thioclavin T, you are able to pick up those the amorphous material, which shows apple green birefringence, which helps you confirm that what you're dealing with is the amyloid material. And this is very important, whenever there is a plasma cell neoplasm, you need to carefully look for the bone marrow biopsy always for any thickening or any material. And typically there is an amorphous eosinophilic extracellular material, and you use Congo red, as I mentioned. And in such cases, if Congo red is negative, then you can work up for other deposition diseases like light chain deposition disease or other capillary glomerulonephritis if the Congo red is negative. But if the Congo red shows the apple green birefringence, very typical, then you need to further characterize that amyloid, either confirming that this is light chain amyloidosis by using IHC, and this kappa lambda IHC helps you confirm that whether it is a AL amyloid or secondary. For the other marker that you can IHC marker that is available is for AA protein. So use a SA protein IHC to be able to pick up the AA amyloidosis. In addition, the positive staining for ApoAI or TTR transthyretin, it helps you confirm the hereditary form of amyloidosis, which, if picked up, can be confirmed by molecular testing further using the Sanger sequencing or NGS for confirming the specific mutation for transthyretin, because nowadays drugs are available. So whenever we are dealing with an amyloid in the bone marrow, in suspected or otherwise, we need to characterize that amyloid to show that whether it is primary, secondary, or it is a hereditary form of amyloidosis, because drugs are available for some of the hereditary amyloidosis, and which can be treated with specific kind of drugs. This is one of the approach for amyloidosis, and now this is how you work up, and mass spectrometry is kind of emerging as a gold standard for the amyloid characterization, though not routinely available or not readily available, but that has kind of emerged further for characterization of this amyloid. So one historical fact, and this is again done by Prashant, that using Lardaceous changes, and the term amyloid was coined by a German botanist, Matthias Sheldon, for plants, and Rudolf Virchow in 1854 used this term for human, and because of this was done because of the peculiar reaction of corpora amelia of the nervous system with iron, and he preferred using amyloid to the commonly used term lardaceous or waxy. So moving to the fifth question, and anyone would like to answer that? A special stain used for the detection of amyloid.
Congo red.
Congo red.
Yeah, Congo red is the commonly used stain that we use for detection of amyloid. So the last case from the case 7. So this was a 60-year-old female presenting with neuropathy, subcutaneous nodules, and easy bruising, and serum protein electrophoresis showed an MBAD, and on IFE this was an IgM kappa. So most of the cases or the earlier plasma cell neoplasms we deal with are of IgG, except of IgM, and Prashant highlighted IgM MGUS. But most of the places you have IgG. But here we had IgM kappa. The serum IgM level was also high. This was 1621. So this was high, and the CBC showed 6800 with a normal distribution of neutrophils. The lymphocyte was on the higher side. The hemoglobin was low. There was anemia, and the platelet count was also low. So 90,000 was the platelet count. So whenever you have anemia, as thrombocytopenia, you need to look at the peripheral smear, and previous had rouleau formation and other things. here, because there is high degree of anemia, the rouleau formation and other things are not that great evident, but still you can see some amount of stacking is seen in the peripheral blood, and you see some abnormal cells. Yes. So you have lymphocyte, some lymphoplasmacytoid cells uh, being shown in a background of slight rouleau formation. And anemia, thrombocytopenia, and abnormal cells, you do a bone marrow examination. Bone marrow aspirate was dilute here. Okay? There were 52% lymphocytes, few plasma cells, and occasional lymphoplasmacytoid cells. I hope you are able to see some of the lymphoplasmacytoid cells here. And traditionally, in this is a further slide showing the lymphoplasmacytoid cells, plasma cells, and you could see some other cells. You notice some other cells. These are mast cells in the bone marrow aspirate, and I have highlighted these reasons for a particular reason in this scenario. So, noting such abnormal cells in a scenario of LPL is very significant, and typically they help you identify the Waldenstrom. So, typically in a Waldenstrom or in scenario, the mast cells, identifying these mast cells is important because they can help you identify LPL. So even though the aspirate is dilute, you're able to pick up that there is abnormal lymphocyte, there are lymphoplasmacytoid cells, and there is some additional cells like mast cells. And typically, sometimes mast cells in help you suspect that you're dealing with an aplastic marrow. But here, in the background of when you're dealing with IgM, increase in IgM, anemia, and lymphoplasmacytoid cells in the peripheral blood, rouleau formation, and you see this bone marrow biopsy showing a quite hypercellular marrow and quite an heavy infiltrate in the bone marrow biopsy. And on higher power, you see those cells, small to medium size cells, and there are some lymphoplasmacytoid cells. There is increase in reticulin as well, mild to moderate increase in reticulin. And now you want to characterize the infiltrate that you have using IHC. And we begin with 320 Ki and then further looking for those abnormal plasma cells. So this is CD20 showing quite a heavy infiltrate. Places there is a paratrabecular as well. And there is nodular, but sheets of CD20 positive cells. And the down slide shows the plasma cells. They are scattered plasma cells and some plasmacytoid cells. Background few CD3 cells, and yeah. So now, so you are able to see the CD20 positive cells, and sometimes looking at the intensity of the stain, just like in flow cytometry, you are able to see the intensity of the CD20 and CD38. Here, a variegated CD20 or a variegated heterogeneous CD38 kind of helps you suspect that probably you are dealing with a lymphoplasmacytoid lymphoma, because you have lymphocyte plasma cells and lymphoplasmacytoid cells, each having varying intensity of these 20 and CD38. The plasma cells showing bright CD38, whereas the lymphoplasmacytoid showing less intensity of CD38 cell. So, looking at the morphology, looking at the heterogeneity of the expression of CD20 and 138 helps you suspect that probably you are dealing with a lymphoplasmacytoid lymphoma. And subsequent, the kappa lambda immunostain kind of here you can see there is a kappa restriction, and on lambda immunostains it is very negative immunostain. So, and further additional now, so So you have a CD20 138 increase with a variegated appearance, which are kappa restricted. So it is a clonal infiltrate, probable lymphoplasmacytoid in nature. Now you want to further characterize those plasma cells or the abnormal cells using markers like 5, 10, 23, PAX5, and all of them are negative. CD23 is negative. CD cyclin D1 is negative. So this is not mental. This is not CLL. This is probably a lymphoplasmacytoid lymphoma, and the presence of IgM sort of confirms that you are dealing with likely a lymphoplasmacytoid lymphoma. So, this disorder, the Waldenström or lymphoplasmacytic lymphoma, is a B cell disorder characterized by the accumulation of B cells, lymphoplasmacytic and plasma cells. And there are two subtypes. One is the Waldenström macroglobulinemia, where there is an IgM paraproteinemia. Like in this case, you have lymphoplasmacytic involvement and an IgM paraproteinemia. That you are most likely dealing with the Waldenström macroglobulinemia, but there could be other LBL of non-Waldenström type. So there are two types of Waldenström the LBL or Waldenström. And when you are evaluating, you need to, before you arrive at a diagnosis, you need to exclude other low-grade lymphomas like CLL with CLL or mantle cell lymphomas, where there could be an additional plasmacytic differentiation could be there, or even marginal zone B-cell lymphomas where there could be an overlap. In rare conditions, rare subtypes, there could be IgM myeloma, which overlaps with the with these parameters, and with the IHC kind of more or less similar, because the IgM myeloma, they are cyclin D1 positive. They express translocation 11, 14, and they are also CD20 positive. So sometimes it becomes difficult to be able to distinguish these two entities together, and their genomic characterization or mutation analysis helps define. So there is flow cytometry, there is an immunohistochemistry, there are biochemical markers, and also there is some genomic markers. And specifically for this Waldenström macroglobulinemia, there is a mutation, one typical mutation, that is MYD88 mutation, somatic mutation. In this is L265P. This specific mutation is present almost in 80 to 90% of the cases of Waldenström macroglobulinemia. So this is not a disease-defining entity, but whenever you have this mutation, you need to rule out whether this is a Waldenström or not. Rarely, some other diseases, some other diseases like CLL, 5 to 6% marginal zone, rarely 5 to 6% cases, but not in IgM myeloma. So when you are dealing with paraproteinemia, IgM subtype, and you have a marrow infiltrate, which is a variegated CD20 138, and you have an MYD88 mutation, you know that final diagnosis is Waldenström macroglobulinemia. So within this Waldenström, there is other mutation. So there is now other mutations have been defined, which is the CXCR4. MYD88 is one gene, the other is the CXCR4, and based on this positivity of MYD88 and CXCR4, you are able to sort of subclassify or risk stratify your Waldenström into different subcategories, and you are able to pick up some of the cases of Waldenström which may not respond to ibrutinib. So based on this markers, you are able to confirm and also pick up or prognosticate or Waldenstrom cases. So as per the WHO 2022, there are some essential and desirable criteria. So there has to be significant bone marrow infiltrate by small lymphocytes with plasmacytoid or plasma cells. And on flow cytometry of these cells, they are typically IgM positive, 19, 20, 22, 25, and they're negative for 10, 23, 103. They can be heterogeneous positive for CD138. And then there are markers as I mentioned, MYD88 and CXCR4 and IgM. So these are some of the updates from the WHO 2022. Prashant, you want to take this 2 slides further? There is another revised IPI scoring system based on this. So where you are able to risk stratify your Waldenstrom. So age, beta 2 microglobulin, LDH, and albumin helps you risk stratify your IPI, the Waldenstrom. So coming to the question 6, Waldenstrom macroglobulinemia is characterized by the following, except anyone
Deletion
would like
17p.
deletion 7. Yeah. So typically they have IgM type of paraproteinemia, and 90% of the cases have MYD88, and around 40% will have CXCR4 mutation. So they do not have deletion 17p. So I think I will stop here, and Prashant can take it further. Yeah. So basically we showed some rare subset of cases where there's an overlap with various other disorders like amyloidosis and low-grade lymphomas and Waldenstrom macroglobulinemia, where you have IgM paraproteinemia.
Yeah, I'll just add a couple of sentences on the flow, how it flow can help. Flow cytometry, basically you can see the lymphoplasmacytic lymphoma in addition to Waldenstrom macroglobulinemia can be defined without IgM also, right? So you can have non-IgM lymphoplasmacytic lymphoma, and it is diagnosed using using flow cytometry or even IFC, tissue biopsies, with the presence of abnormal clonal lymphocyte and abnormal clonal plasma cells. So if they are both are present, then so by flow cytometry, you can identify abnormal clonal B cells as well as plasma cells. And usually, as Neeraj has mentioned, they are IgM positive if there is IgM LPL, or if it is IgG, it can be IgG also. Also, the percentage of non-IgM is very low. Now, these plasma cells, if you look very carefully, if you get these cells, you can clearly see there are B cells which are differentiating toward plasma cells. They are gaining CD38 expression and losing CD20 expression, which is natural, normal maturation pattern of lymphocytes to plasma cells. They can show 25 expression, as Neeraj has mentioned, as per the WHO criteria. They can show even CD138. Some of the cells are CD138 positive and light chain restricted. So using flow cytometry, you can also confirm the LPL, presence of LPL, diagnosis of LPL. Now, this is an interesting factor, a fact about Waldenstrom macroglobulinemia. The disease was defined by Jan Waldenstrom. It's the name of the clinician in Sweden, basically in Sweden in 1994. Now, you know what? He defined this entity with just 2 patients. So the diagnosis from 2 patients, 2 typical patients, he came up with a completely new disease. And that's why it's very important to look at each and every case closely and identify what is different about those patients. And you may come up with a new disease only. So these two patients were typical history was the bleeding from the nose, mouth, had anemia, hypofibrogeninemia, swollen lymph nodes, means enlarged lymph nodes, and neoplastic plasma cells in bone marrow, and hyperviscosity due to increase in heavy chain proteins called macroglutins. Okay, this was, you can see this is a presentation in the journal in 1943. So this is Acta Medica Scandinavian journal list. So this was the interesting fact about the Waldenstrom macroglutinin. Now a quick case. This is now we are just finishing. I'm just presenting a small case which usually you probably heard and read about. So this is the 41-year patient. Okay, presented, and the patient had already plasmacytoma and right acidophilus. So we know that patient has diagnosis of plasmacytoma. Baseline plasma cells, bone marrow plasma cells 6%. Concentration of membrane was 1.1 gram per deciliter, and patient started on treatment, BRT, that is radiotherapy. After 4 months, the patient developed persistent and increasing pain in lower limb, bilateral limb. So lower limb patient had also lower limb paresthesia, weakness, and shows there was lumbosacral plexopathy. The nerve conduction studies have shown lumbosacral exopathy and some motor axonal degeneration. The prolactin was also high. The patient has higher level of prolactin. The patient also developed polycythemia, and this hemoglobin was 17 or 18, something like that. JAK2 mutation was done, which was negative. There was soft tissue edema in the gluteal and hip region. And the patient also had multiple, retrobladder lymphadenopathy, bilateral inguinal pelvic lymphadenopathy. So patient had lymphadenopathy, polycythemia, neural pathogenesis, lower limb neural problem, and soft tissue edema. Anybody? what could be the reason? Is a known case of plasmacyte.
Associated paraneoplastic syndrome.
That is the syndrome, but what is it? There is any definitive name for it.
Poem syndrome.
Poems.
So this is a patient of Poem syndrome, and we define, so we can do VEGF level by using flow cytometry. We have done VEGF level by using cytometry bead array by flow cytometry, and the patient has very high level of VEGF. You can see normally it is less than 100 picogram per ml, which is 1346 picogram per ml. So higher level of this one. So this was a patient of plasmacytoma who developed Poem syndrome. So these are the Poem syndrome criteria. The major and mandatory criteria include polyneuropathy, especially demyelinating, like lower limb going up, and then monoclonal plasma cell proliferative disorder. It is almost always lambda restricted, like in this patient has plasmacytoma. And then there are major criteria that EV, which include Castleman disease or sclerotic bone lesions or VEGF level increase. Normally, as I told you, the normal levels are about 100, but increasing to more than 200 milligram indicates higher levels and have very high sensitivity specificity. And if you are using serum, then the further higher level. So plasma level, we do plasma and serum both, and then you have other criteria which indicates minor, which are categorized minor criteria, which include organomegaly, such as splenomegaly, lymphadenopathy. This patient has retroperitoneal pelvic lymph node, extravascular volume overload. So the patient had pleural edema in muscle region, pelvic region, endocrinopathy. Like the patient has higher prolactin level, like adrenal, thyroid, pituitary, gonad. The skin changes, hyperpigmentation, MGUS, nail changes, the common papilledema, thrombocytosis. These are all minor criteria. So for final diagnosis, the patient must have two mandatory. So these two has to be there. Then one major and one or more minor criteria. Okay. So this is how to diagnose Poem syndrome. There is another syndrome which is this I have not seen, called as a Tempe syndrome, which includes telangiectasia, elevated erythropoietin, erythrocytosis, monoclonal gammopathy, perinephric fluid collection, and intrapulmonary shunting. The one more syndrome which WHO has given is a very rare syndrome, like called ASOP syndrome, that is neuropathy, extensive skin patch overlying plasmacytopenia. So these are few syndromes which are there. One is the poem, which is more common, TMP, and ASOP syndrome is very rare. So I think with that, I will acknowledge along with, of course, the Neeraj who was there with us, and then Kinjal Kajo rose from the biochemistry department for sharing his slide. Tushar Agrawal was DM student, now passed from Tata Hospital of practice in histopathology, and resident and my colleague Anumya Chaturvedi, and complete hematology DMG. Okay, thank you very much. Is
So
there any
Prashant,
question?
I would now wanted to add one point. So with
Yeah, please.
respect to the with respect to some of the syndromes that just described, so typically the plasma cell neoplasms will present with anemia. Most of them will have an associated anemia, but whenever you have erythrocytosis as one of the findings in that, in a case of plasma cell neoplasm, do think that there could be a syndrome. So I have been reading a lot about JAK2 negative erythrocytosis nowadays. I think whenever this fits in a way, if there is a plasma cell neoplasm is there and there is an erythrocytosis, please think this syndrome.
Any question? Any comment? Anything else?
So there is no question in the chat box.
Sorry, got it.
Uh,
Students.
yes, sir.
Okay, then I'll